All right, let's jump right in. Today we're doing a high-yield board review on Tinea and Onychomycosis. We're going to focus laser-sharp on the key data you need for diagnosis and, of course, pharmacological management. Let's get started.
Here's our game plan. We'll start with the foundational concepts. Then we'll get into the weeds on diagnosing both Tinea and onychomycosis. After that, we'll do a really deep dive into the treatment hierarchies for each one, and we'll wrap up with the absolute must-know criteria for when to refer to a specialist.
Okay, Module 1, Core Concepts. Here, we're going to define the pathology and lock down the key causative organisms you absolutely have to know for your boards.
So what are we actually talking about? Well, superficial mycoses are pretty straightforward. They're fungal infections that are localized to the very outermost layer, the epithelium, of the skin, mucous membranes, and their annexes, which of course includes the nails. That's the foundational definition. Simple as that.
Now this slide is a crucial clinical pearl for your exams. You have to know the organism-disease correlation. So, Trichophyton rubrum, that's your #1 culprit worldwide. It's responsible for almost half of all Tinea corporis cases. For Tinea capitis, the scalp, the name to remember is T. tonsurans, and rounding out the top 3 for Tinea corporis is Microsporum canis. Knowing these associations is definitely high yield. On to Module 2, Diagnosing Tinea. We're going to focus here on the clinical findings based on where they show up on the body. Pattern recognition is absolutely everything. Okay, this table lays out the classic presentations you need to know cold. For the scalp, Tinea capitis, you're looking for patches of alopecia, pustules, crusts, and those classic erythematous squamous plaques. In the beard area, or Tinea barbae, it usually shows up as a dermatosis with pustules or even inflammatory abscesses. On the trunk, Tinea corporis has that textbook look, rounded erythematous squamous plaques with a very distinct active border. And in the groin, Tinea cruris presents with intensely itchy or pruritic erythematous squamous plaques. These are the findings you have to be able to spot. All right, let's switch gears and focus on the nails. Module 3 is all about diagnosing onychomycosis and, just as importantly, learning the key signs that help you tell it apart from common mimics.
So these are the fundamental clinical signs of onychomycosis. You really need to be comfortable with this vocabulary. First, pachyonychia, which is just a fancy word for nail thickening. Then you'll see nail fragility and crumbling. Look for distinct changes in color, usually on the yellow-orange spectrum. Onychomycosis is another big one. That's when the nail plate starts detaching from the nail bed. And finally, subungual hyperkeratosis, which is that classic scaling you see building up under the nail.
So, this brings us to a classic board question, a real favorite. How do you tell the difference between onychomycosis and nail psoriasis? They can look incredibly similar, and honestly, it's a very common trap on exams. Okay, here's the bottom line. For distal lateral subungual onychomycosis, or DLSO, the key signs are that subungual hyperkeratosis and the white, yellow, orange scales we just talked about. But for nail psoriasis, the absolute pathognomonic sign, the giveaway, is the presence of that salmon pink coloration, often called salmon patches. If you don't see those patches, it strongly points you away from psoriasis and back toward a fungal cause. This is a critical differentiator.
All right, let's get into the main event, the treatment modules. First up, Module 4, Treating Tinea. We're going to break down the drug hierarchy covering both the systemic and topical treatment ladders.
Okay, for Tinea capitis and barbae, you have to go systemic. The first-line agent is terbinafine. Now pay close attention to the details here. For adults, it's 250 milligrams a day for 12 weeks. For kids, it's a weight-based dose, 10 milligrams per kilogram per day, but for a shorter duration of only 6 weeks. The alternative here is itraconazole. And again, notice the different dosing and duration. 100 milligrams daily for 6 weeks in adults and 5 milligrams per kilogram daily for just 4 weeks in children.
Now, for the topical treatments, Tinea corporis and cruris, your first-line agent is terbinafine cream. You apply it once a day for 3 to 4 weeks. The alternatives are the azoles, but they require twice-daily application for that same duration. Now, here's a key nuance for Tinea pedis and monum. The drugs are the same, but the duration is shorter, just 2 weeks. That's exactly the kind of detail they love to test you on.
And now, Module 5, Treating Onychomycosis. With this condition, your choice of systemic agent is going to be guided by the specific causative pathogen. This is key.
So, when you're dealing with dermatophytes, and they are by far the most common cause, terbinafine is once again your first-line therapy. The dose is 250 milligrams a day. The absolutely crucial point here is the duration, because it depends on the location. For feet, it's a long haul, 12 to 16 weeks. But for hands, it's much shorter, just 6 weeks. Your alternatives are itraconazole, which you can give either continuously or in a pulse regimen, and fluconazole, which is dosed weekly for a full 24 weeks.
So let's just clarify that itraconazole pulse therapy, because it's a more complex regimen you really need to understand. It involves taking a higher dose, 400 milligrams daily, but only for 1 week. Then the patient stops the medication completely for a 3-week rest period. This cycle of 1 week on, 3 weeks off gets repeated for 3 to 4 months. The whole idea is to maximize efficacy while minimizing that systemic exposure.
Now, watch what happens if the causative agent is a non-dermatophyte, specifically a yeast. The treatment hierarchy completely flips. Itraconazole now becomes the first-line agent, using either that continuous or pulse therapy dosing we just covered. Terbinafine gets bumped down to the alternative position with the exact same location-dependent durations as before, 12 to 16 weeks for the feet and 6 weeks for the hands.
All right, our final module, when to refer a patient. Knowing the criteria for a specialist consultation is absolutely essential, especially in a primary care setting.
These are red flags for referral. You have to refer if there's a lack of efficacy after a good 3 to 5 months of appropriate treatment. Refer for severe onychomycosis, and that's defined as more than 5 nails being affected or if over 50% of a single nail plate is involved. The presence of a dermatophytoma or any involvement of the nail matrix, those are absolute indications for referral. And finally, you have to refer if the patient has severe comorbidities, like uncontrolled diabetes, or if they might need more advanced therapies, like a nail avulsion.
So, we'll end with a final thought for you to consider in your practice. You've followed the guidelines perfectly. You've achieved a mycological cure. The fungus is gone. But the nail still looks dystrophic. It's still abnormal. How do you counsel that patient on the difference between a clinical cure, which is a normal-looking nail, versus a complete mycological cure? And how do you manage their expectations for what that final cosmetic outcome is going to be? That right there is a huge part of patient management that goes way beyond just writing the prescription.